See, we are in our laboratory, we are collecting different types of samples. Blood samples. Sometimes clinicians also want to know something related to blood sample collection, maybe order of draw, maybe what type of tube is required to collect a particular type of sample, what are the special considerations when performing venipuncture, or if they want to collect capillary blood, then what are the precautions? Or in case of pediatric sample, what is the correct technique? Sometimes they use very fine bore needle, so that shall not be used. Or if a patient is receiving IV fluid, or they have cannula in place and you want to collect sample from that cannula, what is the correct procedure? So all these things sometimes clinician want to know, or if a patient is receiving IV fluid, sample shall not be collected from the same. So these are the different things which we discuss with the clinician. Or if it is ABG, how arterial sample shall be collected. So that is very important to know. What I mean to say, you have to think what are the different areas where we are interacting with the clinicians, or sample types other than the blood, like respiratory tract samples. You are collecting bronchoalveolar lavage, washings, sputum sample. For these days, endobronchial ultrasound is also there, which they perform endoscopically, and they collect fine needle aspiration sample from sometimes from the mediastinum or some bronchial growth. So what are the precautions for that? If they are collecting fecal samples, what are the different type of samples they are collecting? What is the purpose? What are the tests we can perform through these fecal samples? Maybe stool for occult blood. If there is a sample for stool for occult blood, what precautions need to be taken? If it is urine sample, how this 24-hour urine sample shall be collected? Patient shall be explained properly. If it is urine culture sample, then how this sample shall be collected? If it is 24-hour urine sample for VMA, they are suspecting pheochromocytoma. What is the preservative required in this case? Or if it is semen sample, what are the precautions to be taken? If they are collecting CSF for clinician, they are collecting CSF for different type of tests. So you have to tell them, see, in this sample shall be transported as early as possible. Similarly, other body fluids like ascitic fluid, pleural fluid, pericardial fluid, or synovial fluid, for these also some precautions are required. They are collecting biopsy sample. Biopsy sample may be for routine hematoxylin eosin, or some special stains may be required. Immunohistochemistry, cytogenetics, electron microscopy, certain translocations, next generation sequencing, microarray. So many tests are there. So how these samples shall be collected, transported. For this, a regular interaction between clinician and laboratory people is very important. Cytological sample, you are collecting sample for pap smear, you are collecting samples. This FNAC, you are collecting through FNAC from various areas, or similar to EBUS, endoscopic GI ultrasound is also there. They are also collecting from mediastinum growth, or they are collecting sample from, they are collecting gastric biopsies. Gynecologists are also collecting so many endometrial washing, endometrial biopsy. In microbiology, blood culture, urine culture, culture from catheter, or other specimens, pus culture. what are the precautions to be taken, or in immunohematology or hematology coagulation studies. So many advanced tests, routine tests are available. PT sample, PTTK sample, or samples related to hypercoagulable state. How these samples shall be collected, or whatever we are discussing, how this test shall be interpreted. This is also very important. Now you see laboratory activities in the standard. What they are saying, laboratory shall specify and document the range of laboratory activity you are specifying. See, in our laboratory, we are performing tests related to hematology and biochemistry, or we are performing tests related to hematology, biochemistry, microbiology, histopathology also, and also document, write down what all tests you are performing in hematology, what all tests you are performing in biochemistry. And if suppose in your hospital setup, you have some laboratory away from your main laboratory, maybe close to emergency, maybe close to pediatric ward, maybe close to medicine ward, or you have point of care testing like ABG machine in the ICU, CCU, which is under control of laboratory, or you have collection center. These days, a lot of corporates or other laboratories, they have collection centers. We have 10 collection centers, and you're specifying, see, in these two collection centers, we are not performing FNSC, or at these two collection centers only we are performing FNSC. This information shall be conveyed to your clinician and patient. And sometimes, if suppose somebody is beneficiary of some insurance company or otherwise, they may ask you, see, we will get reimbursement only when test is performed in accredited laboratory. You are saying your laboratory is accredited. So can we get this thyroid testing from your laboratory? Whatever this directory of services you are developing in this test shall be documented in three categories. One category, you are performing test and that is included in the scope of accreditation. Second type of test, you are performing but not included in the scope of accreditation. Third, you're sending to a referral laboratory. Similarly, patients shall be advised about this. And you can claim you are conforming to the requirement of this document standard ISO 15189. Whatever test you are performing in your laboratory, whatever you are saying, you will follow 15189 for these tests. If you are sending some test to a referral laboratory, even if that laboratory is an accredited laboratory, you cannot claim you're following 15189 for those, and you cannot keep in the scope of accreditation those tests which you are sending to other laboratory. So what is required? You have to conform with the requirement of this standard at all places of your activity, whether collection centers, whether POCD, your main lab, your additional labs. And in addition to comply with the requirement of this standard, you have to comply with the requirement of accreditation body. If they have created certain documents, you have to fulfill those requirements. Regulatory authority, and we all have observed during the COVID-19 time, it was mandatory for private laboratory, private hospital, private colleges to fulfill the requirement of this ISO 15189. What they were saying, laboratory shall be accredited. Through accreditation, what they were ensuring, compliance to 15189. And also requirement of the user or the organization, wherever you are providing services from. Now, what type of advisory services, as we are discussing, sometimes clinicians they want to know advice related to choice and use of examination. They may ask you, see, we want to investigate a small round cell tumor in gastric biopsy. What is the immunohistochemistry panel you are suggesting? Or this patient has swelling in both feet. This is pitting edema. And there is also swelling below the eyes. This patient is diabetic for so many years. So, what group of tests you will suggest in this case? Or we want to send sample for electron microscopy, this renal biopsy. What type of preservative is required? Or they may ask you, we are sending this sample. If this test is negative, can we rule out a particular disease? You may say, no, there are certain limitations of this test. Like we observed during COVID 19 time, if this rapid antigen is positive, you can say the patient is COVID positive. But if this rapid antigen is negative, so you cannot rule out the possibility of COVID 19. For that, RT PCR is required. Similarly, there are many situations where you say, like you people who are in the molecular hematology, they have seen if suppose translocation 1517 is negative, then an exon 5 is positive. There are faggot cells in the blast. This exon 5, it is suggesting the possibility of promyelocytic leukemia. How frequently a test shall be repeated? Suppose TSH is 62, then after how much time this test shall be repeated? Or a patient with 3.2 hemoglobin, massive hepatosplenomegaly, 1.5-year-old child, suspicion is of thalassemia, and in the night when patient came in the emergency, the child received blood transfusion. Then how long we have to wait before sending a sample for HPLC or electrophoresis? Or sometimes they may ask you interpretation of the result. Suppose you are reporting hemoglobin A2 36%. Band in the region of hemoglobin A2 is 36%. What is the interpretation? Is it suggestive of thalassemia or something else? All of us know it is, if the patient is of some east, northeast, it is more suggestive hemoglobin E. So, like this, sometimes they want some interpretation from our side. Sometimes these tests are in the equivocal range. Then we advise them to repeat after some time. In serological tests, generally they get settled in one direction. Effective utilization of laboratory examination. Suppose they are writing unnecessary tests. They are writing dengue serology with 1 day history of fever, or liver enzymes are highly abnormal and they are sending every day without any reason. Unnecessary wastage of resources. Advising on scientific and logistic matters. Suppose you are receiving hemolyzed sample from a particular pediatric ward. They are using fine needle. Actually speaking, they are trying to help the child. Child will get less pain. But in the process, sample is getting hemolyzed. They have to tell them, use needle of appropriate bore. If it is prothrombin time sample, then they are thinking we will send with the routine samples. It is taking too much time, or CSF samples are transported very late. So we have to discuss with them. It will not serve their purpose. Result will get delayed. Patient treatment will get delayed. And the clinicians, they should get opportunity. If they want to ask any question about any examination result or their interpretation, the laboratory has appointed reasonable persons to discuss all these things. Or in a patient particular condition, these are the investigation, these are the clinical features, what are the possibilities in this case, or some additional test is required. Can anybody tell me what is the difference between reflex testing and reflection testing? Yes, anyone? Reflex testing and reflective testing. We write in the chat box. I agree. Yes, anyone? Reflex testing and reflection testing. Yeah, reflective testing. Yes, good. See, reflex testing means based on the investigation, you're deciding about the additional examination. A simple example is if suppose age of the patient is more than 50 years, 55 years, calcium is low, alkaline phosphate is high, you are advising, you are suspecting hypovitaminosis D, and you are advising vitamin D level. This is reflex testing. But based on some tests, you are then correlating clinically, correlating with other findings. And you are saying, in this case, it is better to go for this particular test. Suppose it is a case of anemia, or you can say pancytopenia. There is history of weight loss. There is history of exposure also. You are saying in this case, it is better to go for HIV testing. This is reflection testing. In other situation, you are going only for bone marrow, not for HIV. So like that, we have to understand the difference between reflex testing and reflection testing. We need to discuss with the clinician. They need advisory services. Sometimes in the test ordered, what test to be ordered, or you are discussing with them, suppose they want to rule out infective endocarditis and they are sending only one sample. On the basis of one negative blood culture, they are ruling out the possibility of infective endocarditis. This is not the correct approach. Or you are receiving too many blood cultures and the history, 1 day fever, 2 day fever. That is not the correct test to be ordered to rule out enteric fever. You have to discuss with them. When they are collecting samples, when their residents, their nurses, they are collecting samples, how they are identifying the patient, at least two identification. You have to, during training, teach them. Patient preparation, if fasting is required, or sample at a particular time is required, or sample for a particular duration is required, how the sample is shall be collected. When they are transporting sample, so they have to keep in mind sample shall be transported And during this time, when you people have so many collection centers, so many hospitals are coming up, so many branches of the hospital. In one major branch, they are keeping facility of certain tests which are not available in their own other hospitals. They are pulling in samples. This transportation is very important. This shall be transported within reasonable time frame at appropriate temperature, keeping in mind safety of the sample, safety of the person who is carrying those sample as well as integrity of the sample. If sample is transported through pneumatic chute, what precautions are required? How sample is identified? It should be properly labeled. What should be the contents of the label? And when you're receiving sample in the laboratory, information on the label is matching with information on the test request form. And with that information, you should be able to reach, you should be able to locate the patient. And whatever sample load we have, people shall be trained. This logistic issue, we have to guide your clinician, nursing staff, residents, because they are performing other activities also. So with that, this sample collection shall not be neglected. You have to discuss with them, and they shall be trained to collect various types of samples, because your result is only as meaningful as the quality of the sample collected. Then you shall have ability to use acquired knowledge and skill in the practical situation, whatever you are teaching them. This shall be properly mixed, how this prothrombin time tube shall be mixed, how this EDTA sample shall be mixed, not too vigorously, not too lightly. Some minor clot is coming up. Staff should be adequate. Sometimes this clinician, they want to know about the methodology to be used. They want to discuss methodology. They may say, we want reticulocyte count by a particular method, by automated method only. We are providing patient this chemotherapy and we want to know reticulocyte count over a time. Or they may say, we want to have mean reticulocyte volume. Do you have facility for that? Or we want to have that fractionated red cells. They are suspecting some hemolytic anemia, maybe microangiopathic hemolytic anemia, or your DIC. They may say, we want to have immature granulocyte. Previously, we used to do this bent cell count, but now we have automated parameter also. For all these things, in post-analytical, how this result is conveyed to the clinician, you are informing resident. If suppose resident is not picking up the phone, so you shall have some system of escalation. You are responding to responding at some higher level. These results shall be interpreted in full clinical context. You should have adequate history. Suppose previously the prothrombin time was 1.8 and the clinician want to maintain between 2 to 3. You discuss with them. If they are sending prothrombin time again, you shall have adequate history whether they have increased the dose in the recent time or not, so that you are able to correlate. Also discuss with them turnaround time for various tests and CSF, neonatal bilirubin. These are the tests which are always urgent. Suppose there is some transcription error, discuss with the clinician. This is the reason. Or also explain to the clinician the concept of measurement uncertainty